Hi, everybody. Thank you so much for joining us. My name is Ryan McGee. I'm the communications manager here at WellcomeMD, and we are fortunate enough to have Dr. Emily Roush joining us today. She's going to talk about vertigo. She's going to talk about inner ear problems, a lot of different things, and how we can combat that and how physical therapy can help with that. If you are new to WellcomeMD, we are a concierge medicine practice with offices in Richmond, Virginia and Charlotte, North Carolina. Dr. Emily has worked with us before at our Charlotte practice. That's where she's based. And Dr. Roush, I'll let you introduce yourself and get us underway. At the end, we will have a Q&A session. You can get your questions in now if you want by hitting the Q&A box that you see on your screen if you're watching us via Zoom, and get your questions in to Dr. Emily, and we will answer those at the end. So take it away, Dr. Roush.
All right. Ryan, thanks so much for having me. I really appreciate it. And you all, thanks so much for meeting us here today on Wednesday. I am really excited to talk about dizziness with you all today. It's something that is near and dear to my heart. So let's just go ahead and get started. And Ryan, I'll share our PowerPoint with you in a second. So vestibular rehab, today we're going to talk more about dizziness and kind of what all this means. So the vestibular system, I just wanted to give you all an idea of what that is. It's a big word, and so to let you kind of understand what that means is it's just a piece of your inner ear and your brain, and they work together to sense balance, eye movement, kind of make your body aware of that equilibrium. And I put the words David and Goliath because that's how I think of this vestibular system. It's very tiny, but hugely powerful. So any of you who have ever experienced dizziness, I'm sure can relate to this, that it really can take you down and out. If you look at the colored part of your eye, that's about how big this whole system is. It's about the size of a dime. And if you go through your eye and your ear at the same time, when those two lines intersect, that's relatively where this whole system is. And today we're going to be talking about some of the most common reasons for dizziness that we see in therapy. And we're really going to be talking about that blue piece that you can see. That's the inner ear. So Ryan can kind of move over that it almost looks like a snail. That's the inner ear that we're going to discuss today. All right. So just to kind of reintroduce myself, like Ryan said, my name is Dr. Emily Roush, and I'm the owner of Trinity Therapy and Wellness. I am a doctor of physical therapy, and so to treat this vestibular system, we typically go to more advanced coursework outside of our doctoral program, and that's what I did. So I have a little bit more training in treating this. And that led me to open up my own clinic called Trinity Therapy and Wellness, like he said. Once again, I'm based in Charlotte. So I provide private physical therapy in the convenience of your own home. And one of the biggest reasons that I wanted to partner with Dr. Akampora and WellcomeMD is that I feel like we really have the same values at hand when we go to try to treat a patient. We really value that one-on-one time with you all. I think we both have tried to create companies that give you that time to speak with us. Our schedules allow you more time to share your story, us more time to listen without you feeling rushed or kind of interrupted. It also allows us to build a relationship with you, right? Because that's what we want to do. We want to get to know you as a person so we can serve you the best. That also lets us do a really thorough exam to really find what I call the driver behind your symptoms. If we just treat what's going on, we'll never really address why it's happening. So today we're going to talk about the three most common types of dizziness that I see in the clinic. The biggest one is benign paroxysmal positional vertigo. For short, we call this BPPV. It's a big, long word, but I'm sure a lot of you have heard the last word, which is vertigo, right? So the true meaning of vertigo is a sense of movement. And that can either be that you feel like the room is spinning or you feel like you yourself, your body is moving, but it's a false sense of movement. Most often, it's caused by a position change, and it usually ramps up and comes back down within a minute, with the most intense about 30 seconds. So a lot of times people come in and they say, Emily, it happens every time I lay down in bed, roll over in bed, tip my hair in the shower. And as you can think, those are when you're position changing your body or your head. This is that diagnosis that people are referring to when they say, I have crystals in my head or rocks in my head. It's kind of what they are. They're pieces of calcium carbonate, but they're supposed to be there. The problem is when they get in the wrong place, they can really cause you to feel dizzy. The questioning thing about this is we don't often know why it happens, but we do know that it can be really managed with correct treatment. One thing I just want to point out about this, because it's so highly prevalent, I put a stat down here that people who are 65 and over in age, 80% of that population is likely to experience some sort of dizziness, with 50% of that being caused by BPPV. So it's highly prevalent. Highly encouraged for you to go get it checked out because we can really manage it easily. So the next one we're going to talk about is an inflammation issue. And these are long words. That's either an inflammation of the nerve, which is called vestibular neuritis, or it's an inflammation of the entire labyrinth system, which is that blue snail system. When this happens, it's typically from a virus. It can be from a bacteria. And this is also associated with that spinning vertigo. But this is different because it comes on quickly. It's very severe. It lasts for hours at time. A lot of times people are vomiting. I mean, it is violent. The scary thing with this one is that it masks similar symptoms to things like a stroke. So it's very common that people who experience this run to the ER, like they should, get a thorough exam, and it's kind of a rule-out disorder that we have to kind of make sure we're just dealing with the inner ear and not something bigger that needs more addressed. I put hearing loss on here because if it does affect that labyrinth, that's also associated with that as well. The third most common type is Meniere's. And so don't worry about that. The picture on the side's a little blurry, but I thought it did a really great job at showing you what's happening with Meniere's disease. So when someone has this, what it really is it's a swelling of that entire system, right? There's excess fluid, and so it causes swelling of the nerve, of the entire inner ear system. And what that does is it also creates that spinning vertigo sensation. But this can last for hours. It also is associated with tinnitus or tinnitus, however you want to say it, and that's a ringing of the ear. And so people who have been diagnosed with this, the bummer is there's no real cure. What people are typically told to do is to go on a low sodium diet because we know sodium can hold on to water. This is a swelling issue. Low sodium, we hope, would cause less swelling. And so in therapy, since there's no cure, what we can do is we can rely on the other systems of your vestibular system to kind of build up your safety with functional movement when you have a flare up, because most often these people will go fine and then they have it flare and it's kind of a roller coaster for them. So other reasons that you might be dizzy, and we can move on to the next slide, there you go, is an obvious one, a concussion, right? A blow to the head can really make us dizzy. Perhaps you have a migraine and the headache causes dizziness. If you're someone who has any kind of blood issues, vascular issues, if you've ever had a Doppler done on your neck, right? The ultrasound on your neck, they're checking for the blood supply to your brain because if it's blocked, it can cause dizziness. A lot of times people get dizzy when they get up too fast. We hear this a lot in the older population, and that's due to pressure changing your blood pressure. We all know that medications oftentimes have a side effect of dizziness, strokes, anxiety, sinus issues. A lot of people have dizziness from just motion sensitivity. So as you can see, there's a huge list of reasons why people can be dizzy. And that's why it's really encouraged to really get a good examination. So one thing I want to just kind of put out there today is you have to be your own advocate in this. So if you're dizzy, number one, tell someone. If your physician or whomever you told already knows that you're dizzy and they're trying to do something about it, but it's not working, then you need to be that squeaky wheel, right? And say, hey, this isn't helping. We need to try something else, because now you know there's a plethora of reasons you can be dizzy. And so not all physicians are always aware of, you know, different avenues that we can go to treat this. When I worked in Ohio, I worked with some doctors up there who didn't know we treated the BPPV in clinic as therapists. And once they found that out, it was awesome, because now they're like, cool, I can have them go and do a non-invasive procedure rather than do medication right away, and people are getting better. So it's just a matter of kind of educating. All right, so the biggest thing people ask is, what the heck are you going to do for my dizziness in the clinic, Emily? Right? So we know as therapists that there are 3 pieces to your your vestibular system and your balance. The first of that is being your vision. So like I said before, that inner ear is also connected to the eye. And we really have to track your vision. That gives us a really good sense of what's happening in that inner ear. That's why I put this picture of the cop there, because this is kind of what it looks like. I watch how your eyes track my pen test, right? And that tells me what's going on in that inner ear. The second thing that we check is your sensation. So not only just can you feel me touch you, but can your feet and your ankles and your body have a good kinesthetic awareness of where your body is in space as you move, and how to optimally adjust for that so you're not a fall risk. So we typically run you through various testing for static balance. So you might be still, and I'll kind of show you a trick to do at home for that in a second. And then we might also run you through dynamic balance testing of like walking when you're looking around, eyes are closed. Maybe I have you go over obstacles, because that is relevant to your daily life, right? And we want to make sure that your system is intact so you don't fall or trip or get dizzy when you're doing your normal activities. Thirdly, we check that inner ear. Right? And so that's the part with the BPPV group that we really have to check, right? It's highly prevalent. Again, 50% of people who experience dizziness when they're 65 and over, typically it's because of the inner ear. So we've got to check in on everyone. The cool thing about BPPV, like I said before, is it's pretty easy to treat. So if you're someone that has classic diagnosis of this, you can typically get rid of the dizziness in 1 to 2 visits with proper treatment. Okay. Now, if you have had it for years and your balance is still kind of off, we're probably going to work on some other things so you can get back to doing what you love safely. The viral group, the inflammation group that had that like severe attack, they take a bit longer to rehab. And it's kind of tricky with that whole other group as well, with the concussion and the headache. The bummer about the answer to this question is it really does depend. It depends on who you are, how long you've had it going, how compliant you're going to be with the exercises I would give you to do at home, and then also just how well your body adapts to what we challenge it with. Because a lot of times when it's an inner ear dysfunction, we have to essentially give it a workout. So you can't expect to go to the gym or go for a run and be fit after one time, right? It's the same thing with our inner ear. You got to be patient. You got to give it some time to kind of adapt to that change. And Meniere's is a little tougher. Again, there's no cure, so we really just have to rely on those other systems to kind of up their function during an attack. So I want to kind of take you through a couple activities that I would do with people and that you can start doing at home. Ryan will send you out a PDF, or maybe I will, so you can kind of have pictures and still shots of these at home to try. The first one is called VOR ×1. It's an eye tracking exercise. Most often I use this for people who have had that inflammation issue, people who have motion sensitivity issues. So he can go ahead and you can start it, Ryan, and I'll chat through it if it'll let us. So you're just gonna write a little letter on like a paper or a sticky note or something, hold it at about arm's length in front of you. You wanna keep your eye focused on the target as you move your head side to side. You can also try up and down. The goal is to keep the object in focus. You have to keep your eyes on it. I see people do this all the time and they look away with it. That's not the activity. So the other option is you can also place it on a wall so you don't have to hold it, because your arm will get tired. Because generally I have people do this for up to a minute each way, a few times a day. Again, keeping your eyes focused, moving the head quickly. Don't jerk your head all the way to the side. Just go a little bit off the center. All right, so the second thing we're going to go over is just a weight shifting activity. So again, we talked about, can your body, can it sense movement, right? And how do you adjust to that movement? So if you're someone that deals with peripheral neuropathy and you don't have great sensation on the bottom of your feet, how good is your body sensation that happens at your ankles? So in this exercise, what I'm doing is I'm moving both my hips and my shoulders in front of my ankles to kind of shift the weight onto my toes. And then I'm coming back onto my heels, Obviously, I need to practice this a little bit because I keep falling. So that's why I really encourage people to do this in a doorway, so that if you go back, you can kind of hit the doorway. If you go forward, you can press off of it so that you don't fall and hurt yourself. Again, you're shifting the entire body forward to feel that weight change, entire body back to just really practice. Can you catch yourself, essentially? The third one that we're going to go through kind of looks similar to the last because we're using our feet, but it's a strengthening exercise, and we really need strong ankles when it comes to our balance, okay? So again, these are low level, level 1 stuff I give people when they're coming in for vestibular rehab, and these are the things they're doing at home. This is not exactly what we're going to do in the clinic, because in the clinic, I'm going to challenge you to the point where I need to be holding on to you. Right? So these are things you can safely do at home. You're just going to rise up on those tiptoes to feel your calves engage, come down slowly, don't drop, and then come back and lift those toes up to feel the front of your shins working out. The point of this is because we have to have good ankles, especially when we go up and down a hill, for example, because our ankles are the things that keep us from falling during that movement pattern. The other reason we want to practice picking our toes up is so you don't catch your toe anymore on the lip of the stair, the carpet edge, the edge of a rug, something like that. So it's a good thing to practice and hold for a few seconds to really feel it in those muscles in the front part of your shin. The last one I'll kind of show you is one of my favorite things to send people home with. It's a balance training. You want to do this in your corner. Okay, I'll stress that first. You can also put a chair in front of you to hold on to if you need to. So I'm standing close to the corner, but not so close that I'm touching, but close enough I can catch myself if I fall. And what I'm doing is I'm just standing still with my feet together. Eyes are open. You can challenge yourself with eyes closed. You can challenge by moving your head up and down, left and right, and then doing those also with eyes closed. So that's kind of how I progress people. Then we get it harder with your feet, right? So then you can try to put feet next to each other, in front of each other like a tightrope. You can try to stand on one foot like a ballerina and see if you can balance. And then the other option is to repeat that whole sequence on an uneven surface like a pillow or a couch cushion. One thing I want to kind of note here, when I give people exercises like this, they're like, Emily, this is silly. Like when do I stand in the corner and fall over? Well, you don't, right? But we have to make sure you're safe with this before I know you're safe, like closing your eyes in the shower to wash your hair, right? These all still go into our daily life. We go through life closing our eyes. We do go through life standing on one foot, right? You pick up and stand on one foot when you go up to step onto a curb, step over to get into the bathtub. Maybe you're still putting your pants on, standing up without leaning against your bed. So we really try to challenge your system in a way that relates to your daily life. So I hope that you all have just learned a little bit more about kind of what dizziness is. If you are someone who's experienced it, or maybe you are now, I hope that you kind of have a little bit more understanding of what's causing it. And most importantly, I really hope you all walk away today like feeling that you're empowered with knowledge on what to do about it. And so we'll just open the floor. If anyone has any questions, I'll be happy to do my best at answering them today.
Yeah, thank you, Dr. Roush. And yes, now is our question and answer segment. If you have any questions for Dr. Roush, you can send them to us via the Q&A box that you should see on your screen here on the Zoom meeting. Our first question says, Dr. Roush, I was interested in help with tinnitus, but I don't have dizziness. I didn't realize that was the key point. The tinnitus is likely related to damage to the ear or toxicity from the medications. Do you have any help there?
I don't necessarily have help on how to treat dizziness in and of tinnitus in and of itself. I think that my question would be, why is the tinnitus happening? And if we can address that. And I'm not sure how much testing you've had done outside of that to really figure out what's causing that. And then if it's damage to that, you said it was damage to the inner ear?
Damage to the ear or toxicity from medications.
Yeah, if that's something that they've actually deemed you to have, then I would ask what the step is to kind of fix that inner ear or level out the toxicity of your medication.
Next question. Can you please tell us about the technique to adjust the crystals to stop the dizziness from benign vertigo?
Yeah. So the way we test this, it's called the Dix-Hallpike or the Hallpike-Dix, depending on when you went to school. And it came about in the 80s. And really what it looks like is we know how the canals sit. So there's 3 canals, and they're in the front, the back, and horizontal. And the way we go about, first we have to test and figure out which canal it's in. So I think this is a big misconception people have. They know when they lay down they get dizzy, but we really have to figure out which canal your crystals are in. Sometimes they can be in 2 or more. So what we do with that is we would turn your head and lay you down pretty quick, and you have to be pretty specific with how far the head is turned and tipped during the test. That's the test, and then the treatment for that flows from the test. So if you're a positive person and you have, what happens when I lay you down, and let's say you're positive, your eyes will start to go, and they shift real big. So if you've ever seen someone with this, it's pretty crazy. It looks like their eyes are just moving around in their head. And so we kind of hang out there, and then there's a maneuver that we can do. Think about like when you're a kid and you had the game with a maze with a bead, and you have to kind of move it around to get the bead from start to finish. That's kind of what we're doing in the inner ear. We're trying to move that crystal from one point of the tube down to the other where it's supposed to be. So it's a series of head movements. We rotate, we roll, we sit up, and there's a couple modifications that we have to do with that as well, depending on if it's stuck or if it's free floating.
Next question. Does a cervical collar help for an attack lasting more than a day?
In my first thought, first I would ask, why are you having an attack? I think that's the biggest thing to find out. Typically when people, it depends on, so let's say you're having an attack due to BPPV, and you just sat up and you got really dizzy. Most often I tell people, do not lie down and do not fully restrict your movement. Now this is something people do out of fear because they don't want to get dizzy again. But the best thing you can do is stay upright, sit down in a chair, calm down, wait for it to go away. Now you said if it's lasting hours, I think it would depend on how inflamed your system is, or how, what I would say, sensitive it is, right? So if you were to just move your head like this and it's like a quick onset of dizziness, then that's something that I would say we need to go get checked out a little bit more. I think people wear soft collars just as a comfort thing. That's not something I typically prescribe people though.
We have someone who says that they have been dizzy for about 3 months and have had difficulty swallowing, and they want to know if that could be viral.
My first question would be, does anyone know about it? I can't really give a diagnosis to say what that is, but I definitely think it warrants getting a thorough exam. And sometimes that's, they might want to get an MRI. I would definitely get your neck checked out to see if there's anything happening at your spine causing the dizziness and you feeling kind of like you said your throat feels like you want to throw up. Is that what it was?
Yeah, it says they have difficulty swallowing.
Swallowing. Yeah, so I would definitely get some imaging to figure out what's happening in this area as well.
Next question is about tinnitus. Can tinnitus be related to neck nerve pressure or mandible nerve pressure, I assume?
I don't know the research, honestly, behind the correlation between those. I can tell you from experience, I've treated people who definitely have correlation with neck issues with tinnitus. And that's where we kind of get into that cervicogenic dizziness group, where the dizziness is kind of coming from the neck issue. And we typically work on some proprioception skills and manual therapy of the neck itself to see if that'll resolve.
Our next person says that they've tested negative for Dix-Hallpike, but have had symptoms very similar to BPPV for over 5 months now. And what would be your recommendation on how to treat this?
First, I would ask who did the Dix-Hallpike. And then if they also tested their horizontal canal, because that's not tested in a true Dix-Hallpike, it's a different test. I think the other thing that I would say is if you haven't seen an ENT, I would probably go to an ENT for a thorough inner ear exam. They have a lot of different testing that they can do to check the caloric of your inner ear and different motion sense tests there to just make sure the nerves are firing correctly as well.
While we wait for some more questions, if you do have any more questions, I mean, tell us more about how the inner ear is connected to all of this. It seems, I don't know, kind of crazy to me that the inner ear does have such a huge impact on dizziness. What is the connection there, really?
Yeah, so a couple of those pictures you might have seen, there were like yellow pieces that go to the blue. So that's the nerve, right? There are a couple nerves that are linked to those areas. And then those nerves, send a signal to our brain that tell us stuff. They're also kind of sending signals to the eyes because a lot of our balance is related on our vision, right? So if my eyes can't focus with me turning my head, things are kind of off. Also, there's supposed to be, so with the BPPV group, there's supposed to be fluid, right, in that inner ear. And there are also those crystals, they sit on hair cells. It's really incredible. It's very complex. When the fluid, if you have a water bottle and you move it, if you really look closely, the fluid shifts in a different direction. And that's what's happening in those hoops, those inner ear hoops. As we move, fluid moves. It moves this hair cell that has the crystal on it. That sends a signal to the nerve. It goes to the brain. So when that crystal gets off that hair cell and is floating in this water, I like to think of it like a pebble in a pond that's stagnant. You throw a pebble in there, you cause a ripple, you disrupt the flow. And that's how I like to think of crystals in the ear, right? They disrupt the natural flow of what's happening when I'm moving my head and make things just really off. Does that answer your question?
Yeah. We have a couple questions about people who are asking about when they're laying down in bed or when they're sleeping. The first one, can sleeping up straight help dizziness go away? Or is there any exercise similar to that can help dizziness go away?
Okay, great question. So I think one thing that I want to really mention here is your dizziness all the time? Or is it something that you get dizzy when you lay down in bed? Right? So a lot of times I find people really avoid activities so they can avoid feeling dizzy. And we know in the research that if you stay horizontal, let's say you have dizziness and you lay down for hours and take naps and you don't move, it's like your back hurts and you don't ever move, right? And now when you go to stand up, every movement causes your back to hurt insanely because you haven't practiced it, right? Your joints are stiff, your muscles are tight. It's the same thing in the inner ear. So if we stay horizontal or even just static in vertical position, just in bed laying there, and we don't move slowly, we're never like, anything after that is going to be that much more, the threshold, of our dizziness is going to be changed so much that things that used to not cause dizziness might now, because we haven't stayed in a normal realm of activity. Does that make sense?
And then along those lines, any hints as to how to alleviate high-pitched tinnitus when someone is laying down in bed?
I'll be honest with you, I do not have an answer for that one. That's a great question. It might be better suited for an ENT or an audiologist who, I don't know where that ringing is coming from or what might be happening there. If it's a swelling that's happening when you're laying down, I think there's a little bit more to test there. And Ryan, one thing I'll say with a different question that was asked, the person who had the BPPV for like 5 months or 3 months or something else I think everyone can do is vestibular rehab in and of itself can be helpful with a lot of these things, just to, again, give that system a workout. A lot of times in the inner ear, especially if it's a one-sided issue, we have to get the other side to balance it out. And we can only do that through really particular adaptation exercises or habituation techniques that can really help those systems to kind of level out.
Okay, well, Dr. Roush, again, thank you so much for joining us. We will have a recording of this webinar up on our YouTube page, and we'll share it with everyone who registered. So that you'll be able to go back and watch and see if you missed something. As Emily said, we will also have a PDF that we will send out to you that explains those exercises that you saw a little bit in more detail. Dr. Roush, can you let everyone know how they can get in touch with you, or how they can get in touch with your company if they want to go forward?
Yeah, sure. So I have a website. It's trinitytherapyandwellness.com. You can contact me through the website. You can also contact me via email, and that's dremily@trinitytherapyandwellness.com. You can also feel free to call. My number is 980-224-3756. I'd be happy to sit down and talk with anything that you maybe didn't get to share or get answered today. And so, Ryan, thank you so much for having me and all of WelcomeMD. I just really appreciate it. I appreciate you bringing me on and letting me just talk about something that I love.
All right. Well, yeah, thank you so much for joining us, and we'll include your contact information on that email that will go out as well. If anyone wants to learn more about WelcomeMD, we are seeing patients. We are accepting new patients. You can find out more at WellcomeMD.com. That's WellcomeMD.com. Thank you, Dr. Roush, and thank you to everyone who joined us today.
Yes, thank you so much.